medulla has chromaffin cells, and your chromaffin cells secrete epinephrine and norepinephrine. Okay? So adrenal cortex, glucocorticoid hormones, your cortisol, your cortisone, and your cortisosterone. Most one you see is cortisol. Cortisol causes gluconeogenesis, so generation of glucose, so you end up having increased blood glucose. It causes it's catabolism, so it breaks down protein, so you have protein healing. It blocks prostaglandin, so it decreases inflammatory response. Okay, growth hormone suppressing effects, decreases immune response because it blocks prostaglandin. Cortisol is the most potent naturally occurring glucocorticoid hormone that there is. Mineralocorticoid hormone is aldosterone. We know aldosterone helps to increase your body water by blocking the release of sodium and letting go of potassium. Okay. The adrenal cortex also has androgens. So you have estrogen and progesterone there. So if you have something that causes the adrenal cortex to hypersecrete, you're going to hypersecrete cortisol. You're going to also hypersecrete androgens. So that's why you see those patients come in with hypercortisolemia, and they have like thin skin, they have beards sometimes because they have the hirsutism because of the androgen secretion. A lot of times they have masculinizing effects, amenorrhea because the androgen secretion that's associated with that. Okay. Hypofunction versus hyperfunction. We have hyperfunction would be you'd be hypercortisolemia, so you would have what do you call them? Cushing's, and then you have hypocortisolemia, which would be Addison's. So the disorders of hyperfunction, again, Cushing's disease or Cushing's syndrome, hyperfunctioning, virtualization, which you see in women. You'll see a woman that looks like a man with breasts, and then feminization, gynecomastia in men because of the androgen secretion. Hyperperfusion that increases aldosterone. You can have primary or secondary hyperaldosteronism depending on what. Hypofunction, Addison's disease, or secondary cortisolism. And your secondary hypercortisolism are your patients that you give cortisol to on a daily basis, and then all of a sudden you withdraw it. We have those patients who come into the emergency room and they're not talking, they have no family, so we don't know what meds they take, we don't know what they were on at home, and they end up, we intubate them, they're in the ICU, all of a sudden their blood pressure drops, we can't get them to change, we can't get anything, we can't get their blood pressure up, we give them fluids, we put them on pressors, and their blood pressure is not coming up. What do you usually give them? Usually the intensivists give them Solucortaf or Solumetrol to see if their blood pressure comes up, and if it does, it's because they have a secondary hypercortisolism because we withdrew their medicine. We didn't give them their medicines when they came in, okay? And it can give you a secondary hypercortisolemia. So, same thing again. We have this adrenal pituitary axis dysfunction, and we have primary adrenal dysfunction. Okay, primary adrenal dysfunction comes from the adrenal gland. Secondary, meaning that I'm going to have a deficiency in cortisol because my adrenal cortex is not working. Okay, secondary adrenal or cortisol dysfunction comes from the pituitary gland, meaning I have something here that's causing my pituitary to hypo or hyperfunction, depending on which one. Okay, so secondary means that I have either I have too much or too little. Most of the times it's hypofunction. So if I have little cortisol coming from the adrenal cortex, and I don't know what's going on, if I look at my pituitary and my pituitary has decreased ACTH, than is secondary. And then tertiary, if I have a problem with my hypothalamus, so it's not secreting CRH, then I have decreased ACTH and decreased cortisol. Does that make sense? It's the same thing as the thyroid. So you're just going up. Okay? Jamal.
Let's see. A 36-year-old woman presents to her gynecologist with complaints of amenorrhea and hirsutism. She has also noticed an increase in her weight, especially in the trunk region, and easy fatigability. She denies any medical problems. Her periods were always normal until 6 months ago, and her hirsutism has been gradual in onset. On examination, she has a very rounded hirsute face and centropedal obesity. Her blood pressure is elevated, as is her weight compared with previous visits. On abdominal examination, she is noted to have striae and a male-like distribution of hair on the lower abdomen. The patient then undergoes studies that demonstrates increased cortisol production and failure to suppress cortisol secretion normally when dexamethasone is administered. What is her potential diagnosis?
What is her diagnosis? Cushing's. Okay. Why do we say Cushing's? Elevated cortisol. We have the truncal obesity. We said that we have centropedal obesity, meaning that her arms are skinny and her trunk is fat. Blood pressure is elevated. Cortisol causes the increased release of epinephrine, norepinephrine, and cortisol also has vasoconstrictive effects. So if we don't have cortisol, we don't have blood pressure. So blood pressure goes up. If we have too much cortisol, I'm sorry. Abdominal examination, she has a purple striae in her abdomen. She also has hirsutism. Okay, so androgen release gets her male kind of features. Failure to suppress cortisol secretion normally when dexamethasone is administered. So let's go back to this. Okay. So if I have a patient, okay, that comes in and the patient has elevated cortisol levels, okay, they have all these symptoms. If I give them cortisol, what should happen?
It's primary.
It should decrease.
Should cancel out. What should cancel out?
The cortisol. The adrenal gland.
It's the adrenal. Primary.
The symptoms are not going to go away like that.
The negative, the feedback.
The negative feedback. Because if you're saying, okay, well, if I have too much cortisol on board, if I give dexamethasone, it's supposed to block off ACTH. ACTH should stop stimulating the adrenal gland to secrete cortisol. If ACTH does not block this off, then that means that something here is producing too much cortisol. It's not coming from here, because if it was, it would shut it off. If I give cortisol, if I give dexamethasone, it should stop this process. It should stop the release of ACTH, because it would say, you have enough cortisol. It's to send a message and say, stop this. If it sends a message to say, stop this, and this is still elevated, that means something here is wrong. So there must be a tumor or something here in the adrenal cortex that's secreting cortisol. Does that make sense?
Yes. And that's if it's hypercortisol.
Yes. Okay. So if I'm giving dexamethasone, in this case, if I give dexamethasone, it should suppress ACTH. If it's coming from the pituitary gland, it should stop it. If it's not coming from the pituitary gland, if it's coming from the adrenal gland, it will still be high. Does that make sense?
Yes.
How does glucocorticoids increase inflammatory activity? It should be decreased inflammatory activity.
Yeah.
Decrease, right? Because they block the
It should be decreased. Because it rocks the gland. So just change that to decrease, please, guys. Decrease. Okay? Why is hyperpigmentation not found in patients with secondary adrenocortical insufficiency?
So it's coming from the pituitary.
I said hyperpigmentation. When do we get hyperpigmentation? Okay.
And extra-
How do we get hyperpigmentation?
Because
And overproduction
the
of,
body
of,
continues to secrete the ACTH.
pituitary.
Yes. So if it's primary,
We don't have that.
ACTH is not being secreted all the time. If it's secondary, so it says, why is hyperpigmentation not
Not
found in
found.
patients secondary
okay.
hyperadrenal
Those are adrenal
insufficiency?
glands.
Because if I'm not producing a whole bunch of ACTH, I'm not stimulating melanocyte stimulating hormone. So if I'm not stimulating melanocyte stimulating hormones, I'm not getting that increased pigmentation. Okay? But if I had a patient who had a problem where I was still secreting a whole lot of ACTH, then I would have hyperpigmentation. Does that make sense? So Cushing's syndrome, chronic excessive cortisol regardless of cause. Cushing's disease is overproduction of pituitary ACTH by pituitary adenoma. One thing I want you to remember, ACTH is highest 3 to 5 hours after you go to sleep. Cortisol is highest early in the morning. Anybody ever test for cortisol? And the endocrinologist says 8 a.m., not 5 a.m., not 4 a.m., not 3 a.m., but 8 a.m. We have an endocrinologist that writes it just like that. Okay? Because that's when your presumed cortisol level is highest. ACTH level is usually highest at about 1 o'clock in the morning. So if I want to check for elevated ACTH, I'm going to draw blood at 1 o'clock in the morning. If I want to check for elevated cortisol, I'm going to draw blood at 8 o'clock in the morning. Okay. Katarina, you're yawning.
Dexamethasone is a synthetic analog of cortisone. Therapeutically, it can be used to block the effects of conditions with excessive cortisol secretion. Which of the following is the best description of the mechanism of action of dexamethasone? It's ACTH.
It inhibits ACTH. I just had that whole conversation.
Feedback.
Okay. Cushing's, weight gain, adipose, truncal, facial, cervical area. You got the buffalo hump, moon phase, truncal obesity. Sodium and water retention, glucose intolerance, protein wasting because we have catabolism. Renal stones can occur, purple striae, bronze or brownish hyperpigmentation on the skin depending on where it's coming from. Okay. Just what they look like, you see them and you know them from afar. They usually have skinny hands, nice fat face, and a round body. Okay. These are your clinical manifestations. Perlene.
The person has Cushing's syndrome. Which pathophysiologic effect is occurring? Overproduction.
You're all right.
I was about doing all 4 answers. Overproduction of pituitary ACTH.
Beautiful.
But syndrome versus the disease, is your slides like differentiated between the disease versus the syndrome?
Oh, yeah. Chronic exposure to excessive cortisol.
It's like one word, but like.
Yeah, I know. One word that makes it different, and if you see them, they're categorized a lot of times the same.
Same.
All right, congenital adrenal hyperplasia. Adrenal hyperplasia, what do you expect to see?
Large.
Large adrenal gland?
Multiplication of the cells, so it grows.
Something like that. Adrenal hyperplasia, you get more aldosterone and androgens than cortisol. Okay, so you have elevated androgens, aldosterone, I'm sorry, and low cortisol levels.
Because cortisol is on the middle.
I'm sorry?
Cortisol is on the middle.
No,
So,
it's still in the cortex. Yes. But in this congenital adrenal hyperplasia, they usually have more aldosterone and androgen than cortisol production. Okay? And these are the patients that usually you have elevated, what ACTH. Hyperaldosteronism. What do you think you're gonna see with hyperaldosteronism?
retention of fluid.
No cortisol, so
Depletion
low
of
blood pressure.
Hyperaldosteronism. I just want you to think about what aldosterone does. What would you see with hyperaldosteronism? High blood pressure, high fluid volume, okay?
hypernatremia.
Hypokalemia,
And hypernatremia.
okay? I'm sorry?
Hypernatremia.
Hypernatremia,
Yes.
you can see hypernatremia, okay? So, Conn syndrome is primary hyperaldosteronism. Usually you can see very elevated blood pressures, elevated fluid on board, and elevated aldosterone. Secondary is an extra adrenal stimulus, most often angiotensin II, that can actually cause hyperaldosteronism. Okay? Hypertension, hypokalemia, renal potassium wasting, and neuromuscular manifestation. Okay, you get significant hypokalemia because you're letting go of all your potassium and holding on to your salts. Okay. Management of the hypertension and hypokalemia, surgery to take out whatever that whatchamacallit is, whatever is causing it. Anna,
Mineralocorticoids play a critical role in fluid and electrolyte balance in the body. A normal response to aldosterone is to increase acid secretion in the kidney. The hyperaldosteronism that occurs with some adrenal tumors has interesting and profound effects on acid-base balance as a result of increased renal hydrogen secretion. Which of the following will be most likely result in hyperaldosteronism?
okay. Think about it for a second. We're gonna deplete the blood of potassium.
Yeah.
So if we're gonna deplete the blood of potassium, what's gonna happen? The cells are gonna do what?
Exchange for hydrogen.
For hydrogen. If you exchange for hydrogen, what usually happens? I have
Acidosis.
intracellular acidosis, but in the serum, what am I gonna have? Alkalosis. Because remember, it's a negative logarithm. So if all my potassium is coming out of the cell, hydrogen ions are gonna go into the cell. So you're gonna have an intracellular acidosis, but in the serum, you're gonna have an alkalosis. Okay, you're gonna have a metabolic alkalosis. Does that make sense?
Yes.
Anybody have any questions on that? That's easy, that makes sense, guys? Hypoaldosteronism leads to loss of potassium, and hypokalemia leads to loss from cells in exchange of hydrogen, which eventually leads to metabolic alkalosis and intracellular acidosis. Okay. Hypoaldosteronism, we kind of talked about all these already. We'll go through it. Hypersecretion of adrenal androgens and estrogen. Remember, it's going to make the woman masculine and it's going to make the man feminine. Virilization is usually male characteristics that develop on a female, and you see it a lot with in the teenage years or adolescence. This is a woman. That's virilization. And if you look, she has like a male body with a female face.
I was going to say he looks good.
Oh
You're so frontal.
Oh.
That doesn't even look like a man. Well, yeah.
Look at the legs. That's what, yeah, the thighs. The wings. Man.
Only the face is a girl. Well, it could be a boy too.
Well, maybe they have-
It
Looks like a boy.
looks like a boy.
I think it's a boy.
It looks like a boy. It looks
It says hybrid.
Addison's disease.
It's a man, baby.
I can't. It's not a man, it's a woman. Okay. Okay. Addison's disease, primary adrenal insufficiency. Usually you have hypercortisolism. Again, if you don't have enough cortisol because your adrenal gland is not making, your ACTH is going to be ACTH is going to be elevated, and your melanocyte-stimulated hormone is going to be
High.
And what is your skin going to look like? Nicely tanned. Nicely tanned. Okay. Just remember Addison's disease. If you get a question, remember Kennedy. Those of you who know what Kennedy looks like, it will help. Those of you who don't know what he looks like, it won't help. But John F. Kennedy was very, like, if you see any pictures of him, and as a matter of fact, if you look on Google and you try to look for Addison's disease, his picture comes up.
Oh, really?
His picture does come up. Hypercortisolism, you have primary versus secondary Addison's disease, or primary versus secondary hypercortisolism. If you have hypocortisolism that's primary, remember it's coming from the adrenal gland, there's a tumor in the adrenal gland, there's something affecting cortisol secretion from the adrenal gland. The secondary, it's because we exogenously give cortisol and then we withdraw it without giving the body time to make it again. So when we start giving someone cortisol, what the body does, it says, oh, there's enough cortisol, I don't have to make it, okay? So that feedback mechanism shuts down. So your pituitary, your hypothalamus does not secrete CRH, your pituitary gland does not secrete ACTH. All that crap shuts down. And what happens next is your body is getting this cortisol from an exogenous source. And then when you take it away completely and you don't give the body time to readjust to it making its own, you go through this area or this period where the body goes into shock because now the exogenous cortisol is gone and it cannot make it on its own. Okay, it has not readjusted to that. So that's why when someone's on long-term steroids, you have to wean them off. Because when you slowly take it away, the body slowly starts saying, oh, it's getting less, I must start making. Oh, it's getting less, I must start making. Oh, it's getting less, I must start making. So it slowly adjusts to it being withdrawn. But if you just take it away, there's no time for it to adjust.
That's secondary.
That's secondary. Okay? Alright. chromaffin cells. Chromaffin cells of the adrenal medulla secrete epinephrine and norepinephrine, okay? Pheochromocytes, or your cells of your tumors of the chromaffin cells, secrete catecholamines, epinephrine and norepinephrine at an accelerated, rate. Patients who come in with pheochromocytoma come in with severely elevated blood pressures, and they have these intermittent episodes where they have this severe elevated blood pressure, and then they have these horrible headaches, and they have these sweating, because they have this surges of epinephrine and norepinephrine that's produced. These patients, they're constantly fight or flight, okay? And they usually have some hyperglycemia associated with that. So the adrenal medulla hyperfunction is usually what you see. There's no evidence of hypofunction. The tumor of the adrenal medulla is a pheochromocytoma. Your pheochromocytoma is when you see that patient come in, they're hypertensive, they have a severe headache, they're tachycardic, palpitations, and usually they're just going out of their skin. Okay. If it's a young person who is just with this severe hypertension, nothing helps, it's intermittent, and they don't have renal artery stenosis, do a, a CT of the abdomen to look at the adrenal glands to see if there's some kind of adrenal adenoma. Okay. Treatment, alpha and beta adrenergic blockers for the hypertension, and a laparoscopic surgical excision of the tumor with adjunct radiopharmaceutical agents or chemotherapy. Okay. The thing had this on there. I didn't see the reason for it. It's a really boring case study. I don't know who did that. Well, he looks at me, David.
Is this a boring case study you said?
Yeah.
Okay. So we're gonna do it. A 47-year-old woman is seen in her primary care physician's office for her annual screening. She has a history of hypertension and is considered obese according to her BMI. Her physician discusses her laboratory results with her and explains that she has type 2 diabetes. Insulin resistance has been implicated in numerous cardiovascular diseases. Adipocytes or fat cells release a number of hormones that are altered in obesity and have an important effect on insulin sensitivity.
Okay, answer this question. Now, what does this have to do with the other one?
Oh, so glucagon excess may also be as important as insulin insufficiencies of diabetes. Glucagon stimulates lipolysis. Can we read the answer at the end?
You can read the answer at the end.
Okay. Lipolysis has a ketogenic effect caused by the metabolism of free fatty acids in the liver and stimulated by glucagon. And then it says a whole bunch of other stuff of why the other answers are not correct.
Oh, no, correct.
Yeah.
Since you're already doing that, David, you might.
All right. Obesity is present in 60 to 80% of patients with type 2 diabetes and is a major contributor to insulin resistance by many mechanisms, including maintenance of oxidative phosphorylation in cellular mitochondria. Resulting in reduced insulin-stimulated mitochondrial activity.
There you go.
Yes.
All right, we're done. All right, so pharmacology, you have a quiz as we start. If I don't give you a quiz on CNS, then you don't have exposure to the questions.
Yes.
Is it a group quiz?
Fortunately for you, it is. Alright, so at 4:30 we'll start and we'll go through the PowerPoints. The only drugs we're talking about really is diabetic agents and thyroid agents. Huh? So it won't be long, but we can't start without words, right?
Did you release the exam questions?
No, because the end, some people wait until 1 o'clock. You don't understand. Some people wait until 1 o'clock to do it.
So they can't try because we're trying